actually. We need their opinion. And the thing is, there is no wrongs here. It's difficult to choose between two rights. This is the problem.
شكله يعرض الكيسز بعد ما احنا
هم يعرضوها هنا هنشوف ممكن نصور هنا بعدين نرجع لما نتكلم. احنا هنرجع دلوقتي بس هنشوف.
Okay, let's start now with a very simple question. We know we have different refractive modalities, laser vision correction modalities. For example, if you have a case like this with a very normal cornea, normal vision, normal pachymetric profile, normal elevation profile, normal optometric releases, normal screening, and normal biomechanics. And this patient is 23 years old and is suffering from minor 3 diopters of myopia. Which type of refractive surgery you will do for this patient? Surface ablation, LASIK, or KLAS? Let's start with Andrea.
What is the prescription?
It's minor 3D, pure myopia.
Maybe smile, KLAS.
Okay, so you prefer KLAS. Why do you prefer SMILE, for example, for this patient?
Because it's probably less painful, less disruption in the corneal nerves, maybe a small advantage in biomechanics. That's the main reason.
So your preferred technique is SMILE or KLAS?
Well, actually, it's complicated. So for prescription below 3, I prefer SMILE, LASIK.
LASIK.
For higher prescriptions, I prefer SMILE. It's a matter of standard deviation because
If it's minus 3.5.
of course, it's borderline. Of course, we pay attention to other details as well. But in terms of standard deviation, the most precise instrument we have in medicine still remains the excimer laser. Every pulse is 0.25 microns, which is amazing. While SMILE is like an excavator, and the standard deviation is 4 microns per interface. So you need to double it because you have 2 interfaces, and maybe your standard deviation goes up to 8, which is more or less half a diopter. So for higher prescriptions, SMILE is relatively better, also taking into consideration the biomechanics. For smaller prescription, I would prefer LASIK. This is borderline.
Professor Moyan?
I agree to a large degree. 3 diopters is, you just hit the limit between. Below, it would certainly be LASIK, also because SMILE ablates unnecessarily much cornea due to the extra cornea. Above 3, I would be increasingly inclined towards SMILE. Also, below 3, the need or the expectation for ultimate precision to the quarter of a diopter is even higher because they do see relatively well already before. So their LASIK is preferable. So at 3, I would say to the patient, either roll a dice, or if you want a theoretical advantage of biomechanical advantage, let's go for SMILE. If you want ultimate precision and later on, how old was the patient?
23.
With 23, the risk for later even add-on myopia of a half an hour or so is higher. So retreatment is easier with LASIK, and retreatment with SMILE affords its primary advantage. So if I had to decide between you put the pistol to my head,
Yeah.
LASIK.
Okay, Lisa.
So I'm very grateful I don't have to make that decision since I'm not a surgeon. However, I think the only procedure where you know exactly how much tissue you removed is an electrical extraction. And the reason that LASIK is so precise is because they have years and years and thousands of patients to adjust the ablation. It wasn't that precise when we started. So I prefer to know exactly how much tissue is removed, and it's not a matter of pre minus post CCT because there's water redistribution. So that's not going to necessarily give you how much tissue is removed. And also with any biological parameter, there's always a bell curve, so I'm not convinced they're all 0.25 microns per pulse. I'm just not convinced of that. I think some people, maybe more, some people will be less.
Question for you about the surface ablation. Some people are thinking about surface ablation as the best biomechanical option for this patient. When you think that biomechanically it would be better to do the binary treat, and of course the enhancement later on will be easier.
So you noticed I said lenticular extraction instead of smile.
Yeah. Okay.
Surface ablation gives you, not two regions. You have one region and your bed is bigger. So if IOP goes up, it's going to be borne by everything that's there. But it is more painful. It takes much longer to settle down. And it's an ablation, and I don't think you know how much you removed. And in fact, in the early days when they had large beam and a traveling aperture, they would get scare steps, and they would also get central islands because it would, there's a lot of you get little explosions, of debris. It's pulled out. It's not burned. It's pulled out photoablatively. So it almost the pictures. I don't know if everybody's seen them. It looks like mushroom clouds coming out. And those early procedures, they would bounce the water in, and they would get central islands from water redistribution. So, if you want one region, you know that when IOP goes up as they get older and develop glaucoma, surface ablation would be good. But I'm actually looking forward to seeing the results of the biconvex lenticular extraction.
Rahman, this is one of your sons, and he is wanting to get rid of the glasses.
Yes.
And you have of course, the accessibility to all the machines involved.
Yes. Actually, I keep the LASIK my last choice because I believe that in cutting the flap definitely affects the biomechanics of the cornea, and the rate of regression in LASIK is definitely higher than the other procedures. And I'm in between the surface ablation or the femtosmile. Honestly, it depends on the patient's need. For example, here in Egypt, for the military college and so, definitely I'm going to be PRK. But if it is my son and everything is okay, I can do for his smile.
Use mine for
Yes,
them.
yes.
Use mine at 3.
Yes, and now, honestly, I'm getting lower than usual for the smile. I'm doing minus 2.5, minus 2, and even minus 1.5. And the patient is seeing 6 sharp, 1.2, 1.5, and sometimes 2 with the smile. So again, you know that I'm advocate for smile for a long time, and my route were from 1 to 3, usually PRK, and above 3 smile, and above 8 or 9 with ICL. And keeping the LASIK just for the hypergrowth of the next SCA.
So Mustafa, what's your preference?
It depends. He's 18 years old.
He's 23 years old. 23.
23. So, of course, his activity and how he uses his eyes, it's involved in sports, for example. Also, if his job needs a lot of
He's a regular young
for
man.
days, yes.
He's a regular young man.
Working in computer for a long time, so we have to take the dry eye, the effect of the procedure on the dry eye status of the eye. So, of course, there is other things to take in consideration. especially in our country, is the economic status. So nowadays, when we offer the patient the three options, many of them now, stated, they go for the least expensive procedure, which is PRK. If in this condition, PRK is a very good option. We do transcatheter PRK, the pain is less, the effect on the dry eye is less, and of course it takes more time to stabilize, of course, with the pain issue, but with the PRK, the pain is much less, especially with the outfitted with the contact lens. So I think PRK in this patient and his age is a good option.
So this is what I'm trying to present. No life is wrong. Smile slash basic slash smile. We will see smile PRK. So everyone is right, and all techniques are safe for this patient. There's no specific contraindication or indication for such a procedure. What if you have seen the other eye of this patient? It's a classic ectatic case in his other eye. It was not a trap, actually. Yes, it was. This is not, no. Consider it another case. To start from the beginning, if you have a patient seeking refractive surgery and has a contralateral ectatic changes on the other eye. When you do refractive surgery, corneal refractive surgery, for the sound eye,
How much is the best correct visual acuity in this eye?
for this patient,
Yeah.
it's very cool.
Very poor.
Yeah. I'm talking about the sound eye, not the
Well,
management of keratoconus now. I'm talking about the other eye. This is a good eye for this patient.
well, still,
And he's seeking refractive surgery for the sound eye.
well, someone published that the cornea is not a piece of plastic on GRS 2000. And probably this patient is still a good candidate for ACL if there is enough anterior chamber depth. For sure, in the first study. In this eye, it's more tricky, but it very much depends on the motivation of the patient. If he's seeking some spectral independence, of course, we can provide him at least partial spectral independence because we are restoring 100% of vision in the first eye without improving all the biomechanics effects. So ICL, I believe, is a good option, maybe in combination with some laser to improve the normalize the curvature of the surface of the eye. So it's a bioptics technique leading to spectral independence in one eye and maybe in the second one.
Professor Neuhan, what you do,
And the ICL is a piece of plastic.
okay.
A piece of plastic. So you can put whatever you want on it.
For me, the answer, would you do laser surgery on the sound eye? Definite no. Okay. A definite no. If they ask around, as patients sometimes do, I can recommend somebody to you who will do it. I disrecommend strongly, and I will not do it, period. ICL, if the patient's motivation is super, and if the patient realizes that, as you said, the spectacle corrected vision in the keratoconic eye is bad, and if the patient realizes that there is no refractive surgical answer to the other eye, so it will remain a monocular
Let's say he's wearing a hard contact lens and he's happy with it, with a keratoconus.
If he's happy with the hard contact lens and absolutely wants nothing for the other eye, I see it.
Would you think of any laser refractive surgery combined with any cross-linking technique for this eye as a
For the sound
prophylactic?
eye? For the sound eye?
Yeah.
Prophylactic, no. Cross-linking? No.
One, the cross-link keratoconus is a bilateral disease, and he has keratoconus in his left eye. I would suggest cross-linking the sound eye.
That be the answer. Prophylactic in the sound eye, with all those parameters, I would not do. Of course, I would tell the patient, It is not a monocular disease, it's an asymmetric disease for all practical purposes. It's an asymmetric disease, so don't miss annual controls.
And don't rub your eye.
And don't rub your
If you don't have follow-up for this patient, if you don't have, you cannot control it.
you again.
Yes, they will not come to you again. They will not follow up.
If follow-up is not guaranteed, I would be very wary to do anything at all. And then just prophylactic crossing. First of all, crossing, of course, the other, and see how that works. And that they will have to have follow-up anyway. So there's no follow-up guaranteed. The patient does not wish any follow-up. Must look for a different ophthalmologist.
Okay, Professor Cencia, I sent those data for you, seeking your recommendation. I know you are familiar with VAE, or very asymmetric ectasia, and right now we have cornea with very weak biomechanics and ectatic changes, and other cornea shows zero TDI and CBI on green, and no abnormalities in the topography. Would you recommend?
Since the core visit gives one global answer, if there was a way to detect asymmetry, there may be underlying biomechanical asymmetry that you can't detect with the core visit. I don't have to go to touch it here. I think ICL is a good idea. Cross-linking, what I don't know is...
I'm not talking about refractive surgery right now. I'm talking about cross-linking.
Well, cross-linking...
Do you think it is recommended to do cross-linking for this
There's
patient?
a risk it might change his refractive, because cross-linking, it does not freeze shape, it stiffens, and in stiffening, it could change his refractive.
Rahma, what's your opinion? You mentioned
Can I say one more thing? Somebody told me once that cross-linking, people's eyes don't itch anymore after cross-linking. So it may be a heavy-handed way to get him to make sure he doesn't rub his eyes, who knows?
Actually, my opinion is to cross-link the right eye.
Even if the biomechanics is good and the patient is capable of doing regular follow-ups?
I don't trust the patient, our patients, for the follow-ups.
If he's your colleague, for example, and he's coming regularly and having a regular follow-up?
Pressure, yes, I can wait and follow him and not But my belief is keratoconus is a bilateral disease. It usually progresses, especially 23 years of age. It didn't exceed the 30s with the age of biomechanical stability. So I prefer to cross-link the eye if I'm not following him.
I have a question. I mean, an eye like the sound eye here at 23 has in my experience, has a very high chance that any progression that it will show over time will be very slow. If at 23 there's not the least sign, the other one is progressing that way, then the prognosis for extremely slow further progression is very high. Would you agree? And then they save themselves into the age-induced cross-linking and the stiffening of the cornea as they get older. And even if they may get some ectatic change, slight ones, they will probably be happy with spectacle correction for a long time, if not for always, with this high asymmetry.
Well, Mustafa, if the patient is 37 years old,
10 years old?
he's 37
30
years
years. Okay, but I want to raise a point regarding the eyesight. This condition is a dynamic condition. It is changing over time, as we all know. So if you encounter an ICL, then you are not sure that it will have, if the condition progresses, it will be a coma, the patient will not be happy with the agent. Again, sometimes if this is progressive, you need to do cross-linking, not only cross-linking, you may need to have rays to drive the cornea so that you get the benefit of your ICL. Sometimes if you do this, and you put your ICL and you don't regularize the cornea, the patient is still complete. So it depends. When you will put your ICL, you prepare the cornea for one thing, or you will put the ICL and then you will do
أنا
the
مع الرأي
repair
ده.
whatever.
أنا مع الرأي ده.
So I will implant the ICL in the sound eye at the beginning, so the patient is happy the day after. So the patient trusts me, and later we can do the painful procedure. We can regularize the second eye, wait a few months for it to stabilize, and eventually implant the ICL just to fix the refraction in the second eye. Of course, there is no procedure which is lasting forever, not the IOL, nothing, because of many reasons we know very well. Just in case it will be needed in the future, we can replace the ICL with a new one, because it's an upgradable procedure if the patient is very much motivated.
In your country, the patient can afford that.
I know that's another issue. That's if you want my son, let's say.
Moving to the next question, Mustafa.
This patient with this criteria is 30 years old.
No, we are moving to the next
Ah,
question because of time. This is a patient with high myopia, it's minus 12 diopters, and as you can see, he has a very thick cornea. It's like 550 with no elevations, and he's seeking refractive surgery. What will you do for this patient? It's minus 12 diopters.
For this, definitely the anterior reflex allow. Yeah, that's 2.4.
It's 2.4. This is a real patient, by the way. He has a very shallow AC. He can implant an ICL, and he has a thick cornea, and he's minus 12.
No, I wouldn't do.
Any refractive surgery?
No, how old is he? 30 years old?
She's 20.
37?
She's 20. She's 20 years. So Rahman, this young lady wants to get married. She doesn't like the minus 12 diopters of myopia, and she can't tolerate contact lenses. What do we do for this
For her
patient?
is to do smile for minus 10 and then to wear glasses for the minus 12.
So you can do smile for minus 10.
Yes.
You can't do LASIK for minus 10?
No.
Why?
Regression is very high. Biomechanics are markedly affected.
But if it's
smile-
not fit for LASIK, it's not fit for a smile.
No, no, there's a difference. There's a difference. We published paper for the high myopia after smile in cornea in 2021 with more than 10 diopters when our machine was correcting up to minus 13 and minus 14. And we found after 6 years the regression is minimum and 95% of patients preserve their own vision after surgery. So
If you have a 550 micron cornea, and you're going to 10 diopters of,
we will obey the rules as we said. The residual stromal level should be more than 280. Okay.
how much tissue will you remove roughly?
28% maximum.
No, I'm talking in this case, you have experience with minus 10 diopters. You have a calculation in your mind when it
More
comes to smile,
than 100.
not more than 100.
Yes, like the laser.
And it will correct 10 diopters?
Yes. Sure.
Do you agree with Dr. Masri?
I am not going to disagree. I have no legs to stand on, and no experience with treating people. But the images I showed in the beginning, the last one was over 10. These were early days. They did minus 16, they did minus 18. Actually, I went back and checked afterwards with the surgeons. None of them showed up with ectasia, but they were all Asian eyes. But transition to 9, and so you relate to 9, so you get rid of you reduce some of the biomechanics, but since this person's probably not Asian, not East Asian anyway, yeah, I think your current safety thresholds are good.
Professor Leuven, the young lady traveled to Germany to meet and the great Professor Noyan to find a solution because she didn't find the solution in Cairo. Do you have a solution for her?
Well, not one that I would full-heartedly recommend, number one. Number two, I would tell her you're 20 years old, you're minus 12. The probability, just from clinical experience, that myopia will increase over the next years, will increase further, is less than improbable, much less than improbable, very probable at that age. The existing options are phakic IOL, which would be the first thought, is ruled out by insufficient shape again. Surface and LASIK are ruled out by because of non-recommendation, let's put it that way. I used to be the chairman of the Refractive Surgery Committee in Germany, and we limited even the transition zone to can be in certain cases to maximally 10 with LASIK and, by the way, with SMILE. The shown not so terribly high advantages of SMILE over LASIK, as you have shown, do not justify giving SMILE an extra thing. So I would absolutely limit correction in this eye to 10 diopters with SMILE, and tell the lady that's all I can do surgically in a responsible way. For the rest, you will have to see how you correct your remaining -2 or later -3 or so. My recommendation would be give it a try with a very good contact lens fitter for soft contact lenses. She has 1.5 diopters of astigmatism. That's correctable by a soft contact lens. That's what I would urge her to give another try.
If you're going to correct -10, do you think of some sort of augmentation procedure like injecting cyanide with Hayden in the pocket and do some quick cross-linking?
I don't have, my only experience with such procedures is literary. I don't have an own view and an own experience for that. And as long as that's still in development, with all the nice theoretical thoughts about it, I would not recommend it to a 20-year-old Hanoi.
Then she took the train to Italy seeking a clear lens extraction.
No.
Would you do clear lens extraction for this young lady?
No, it's definitely not my sport for a lady like this. So actually,
Why don't you recommend clear lens extraction in such a case?
no, it's too dangerous because, first of all, 100% damage is loss of accommodation.
You can implant a trifocal or something.
No, that's not accommodation. That's pseudo accommodation with side effects. No, so third, in our when we become doctors, we swear not to create any damage to the patient. So I will create the damage, first of all. Second, I'm very likely to induce a retinal detachment because she's young, she's myopic, likely not to have a vitreous detachment yet, so it's definitely not a good idea. So I would tell this lady that she is falling in the 1% of cases that we refuse to do any surgery on. If she starts crying, maybe I can tell her to go to London, to the London Vision Clinic, and meet Dr. Reinstein because they have an open SMILE laser platform and they can do treatment with no limits. So maybe if she is lucky, she will be treated in London, not in my town.
But will you recommend that she will remove 12 diopters with SMILE?
Well, it's doable. It's doable. Dan Reinstein did something like this. I'm grateful to him because they are improving this technology for all of us. So it's technically doable. So maybe if I could have an open platform like he has, it's an option on the table. But for very limited cases, maybe older patients.
If she's 45 or 47 and there is already PVD, you can disease of the vitreous is already liquefied, and
We-
the accommodation is already lost when you do clear lens extraction. In this case,
Yes, so in this case, I would go ahead with the clear lens extraction, yes. After the age of 45, yes, if there is a posterior detachment of the vitreous. In that case, yes. Only in that case, yeah.
one last question about thin corneas. You have a limit for thin corneas? If you have a case with thin cornea like this, it's 480, and she has a good biomechanics, and she wants to correct 3 diopters of astigmatism, and you correct the 3 diopters for this patient. Which technique will you choose?
37 the age,
Yeah,
healthy cornea,
healthy cornea, everything is perfect, just suffering from
LASIK.
normal thin cornea.
LASIK. If the cornea is healthy,
So you can cut corneas less than 500.
no problem. If the cornea is healthy, it's not a matter of thickness. It's a matter of being healthy. So I will go ahead with LASIK.
Anybody has another recommendation for this patient?
The corneal thickness alone is not a parameter, of course. Sub 500 has an exclamation mark. Perry Binder has, a long time ago, published a giant series of sub 500 micron ablative surgeries with more than 10 years of follow-up, and has not shown any connection to increased ectasia risk. 3 diopters of astigmatism around the spherical equivalent of close to 0, right? Did I understand? The spherical equivalent of close to 0.
Zero sphere.
0 sphere. So it's a unimeridional ablation. Yes, I would tell her that, and we will stay with a bed of way above 350 microns with LASIK. Yes, I would say that that's justified and responsible. If she
I'm going to do for this smile.
Do smile.
Smile for pure astigmatism with thin cornea. Marvelous. It's not evidence-based up to now, but from our clinical experience, -3, -4, -5 pure astigmatism. Perfect. This is something new.
Yesterday I presented a case like this with smile extra and showed ectasia.
No, it's not extra. No, I do
Well,
not believe
even
it.
with extra, I mean even with extra, it showed ectasia.
If there's a normal cornea with pure astigmatism, you can do smile. This is the one. My cut-off number for the thickness is 460. Less than 460, I do not touch that. 480, we have the option of either PRK or smile. PRK is not so because of the haze for the pure astigmatism, so it's either between smile and
Mustafa, will you do PRK for this case?
No, maybe a family basic.
Family basic.
Some flap can if everything is as usual.
Running out of time, actually. Enjoyed your company. We will move to the other panel.